Hello, good afternoon, good morning, and good evening to everyone who is joining today's session to learn more about COVID-19 updates, but also other respiratory viruses. My name is Alexandra Kuzmanovic, and we haven't had this session with Mike and Maria, Dr. Mike Ryan and Dr. Maria Van Kerkhove, in a while. So good afternoon. Thank you for your time. Before I give the floor to you, I will just remind our viewers, for those who may have forgotten or who haven't joined us before, that if you have any questions for Mike and Maria, if you're watching us on X, you can use the hashtag AskWHO, and I will pass the questions. If you're watching us on other platforms, please use the comment section. We have a team of colleagues who are monitoring those and sending the questions in real time. So thank you for joining once again, and thanks to both of you. As I mentioned, we haven't really spoken about COVID in a while, at least not in this platform, conversations on social media. So maybe we can start with an update, what is new with COVID, and how wide the virus is spreading at the moment.
Thanks. Alex, thanks for having us back again on doing this. What's new with COVID? Well, I mean, despite it may not be the headlines anymore, the virus is still circulating and it's still around. So we are still tracking it around the world. We're looking at its impact. And, you know, the bottom line is that this virus is circulating in all countries at the moment. We are seeing quite intense circulation, particularly in the Northern Hemisphere in the winter months, which is typical of what we see with other respiratory pathogens. But it's about 10% of the positive samples right now for respiratory samples. Flu is increasing as well. So what's new with COVID is that COVID is not the only pathogen that's out there. It's circulating with influenza, it's circulating with rhinovirus, adenovirus, other respiratory pathogens that typically circulate, as well as other bacteria that are in circulation. One of the things that's difficult for us right now to track is how much of the virus is in circulation around the world. So we have countries that are reporting cases to us, but we also use other surveillance systems to help us track this. So for example, wastewater systems. In a number of countries, the data that we have from wastewater systems is that the amount of virus in circulation is anywhere between 2 to 19 times higher than what is actually being reported. In the last couple of weeks, though, from the wastewater systems, we have seen a decline in the amount in circulation, so we may have passed a peak of SARS-CoV-2 circulation, not just in the Northern Hemisphere, but also globally. Remember, SARS-CoV-2, the virus that causes COVID, hasn't really reached a seasonality, so it's taking advantage of circulating. The good news of COVID is that the impact of COVID has significantly reduced in recent years. And so we're not seeing as many hospitalizations, as many ICU admissions, as many deaths, but at the same time, we're still seeing around 10 to 12,000 deaths per month. And this is mainly among older individuals, people with underlying conditions, people who aren't vaccinated. And this is something we feel we can do something about. So while we're not seeing the same level of impact of COVID, it's still causing significant burden, even in hospitalizations and ICU admissions, although not as bad as it was a couple of years ago. So it's hard to articulate and communicate that we're in a better situation, but we're not out of the woods yet, and there's a lot that we can do, and I know you're going to have some questions later about what we can do to actually prevent severe disease, death, and also prevent post-COVID condition, but we can talk about that a little bit later.
Thank you very much, Maria. Mike, any of your reflections, please?
Well, I think what we're really seeing a phenomenon that's like in life. Memory is a mixture of time and distance. The further you are away from something, the more likely you are to forget. The longer you are away from something, the more likely you are to forget. And I think our immune systems are a little like that. You know, the longer in time you are since you've had an infection or had a vaccine, it takes longer for your immune system to kick back in. The more unlike the previous infection, the more unlike the virus that caused your previous infection is to the one you have now. Again, it takes time for your immune system to adapt. So I think what we're really seeing is that totality of that. We're seeing increased reinfections either due to loss of immunity or just because the strain is just slightly different. But we're seeing more infections and continued infections. But what we're really seeing is that the protection offered by vaccines against severe disease and death is remaining. And this is key, because what it means is you may get reinfected, But if you are vaccinated, particularly if you've got a full course of vaccines and you're an older person or someone with an underlying condition, the chances of you dying from that COVID infection are way lower if you've been vaccinated. And I think that's the message here. Learning, we've said since the beginning, Maria, learning to live with this virus. We've said the virus will never go away. That was not a prediction that we wanted to make, but it was just the reality of how we live in this biome, in this ecosystem. Learning to live with the virus means ensuring that we're protected from it and that those most at risk continue to be protected. Maria is outlining there the challenges we have with tracking the virus, and we need to keep tracking it. And Maria and her teams and many others around the world are working to try and come up with sustainable ways of tracking this virus. And during the pandemic, we had everyone reporting everything, all hands on deck, and that was important. I think we've overshot the runway and we've gone to the other side now, which is kind of underinvesting in our ability to track the virus. Hopefully, with these new techniques, survey-based methodologies, environmental and sort of wastewater sampling, sentinel surveillance, this mightn't mean much to people out there, but these are really simple techniques for doing population-based surveillance, and they allow us to track the virus, but not only track the virus, track its impact on our population, track its evolution and the evolution of the clinical disease that it causes. So if we can continue to do that and continue to make sure that people, the older persons in our communities, people with underlying conditions, continue to be vaccinated and boosted as needed, then I think we will continue to succeed. But that doesn't mean we have thousands of deaths reported in a month. Exactly. So this disease is by no means turned itself into a mild disease overnight. People who are susceptible can become very, very, very sick. So we need to be very vigilant, but we also need to put COVID and SARS-CoV-2 as a virus with RSV, with influenza, with other adenoviruses and other viruses and bacteria that cause respiratory disease, and deal with respiratory disease and winter respiratory disease in particular as one challenge that we face. So, and I think we're making progress on that too. So, the news not good that it's still here. News good, the vaccines still work.
Thank you both, and we are already receiving quite a few questions. And maybe speaking about vulnerable populations, we get a question from Sohel Rana, watching us on Facebook, who says that they are an AIDS patient. And the question is, how can we get recovered from COVID-19? Is there any chance to break out against it?
Well, first of all, solidarity with all those who are living with HIV now, and I hope you have access to therapy and access to things you need to keep yourself healthy. HIV is now a disease that's perfectly treatable. Well, people live with that virus for their lifetimes, and maintaining access to antiretroviral therapy becomes absolutely essential. And what we saw in COVID was people not only not accessing COVID vaccines, but losing access to their antiretroviral therapy. The double whammy, because all of a sudden, a virus that affects your immune system, the HIV virus, gets back in control, while another virus that exploits any weakness in the immune system gets on board. So that combination, and that's a deadly combination, and a lot of focus went in countries, and I don't know stories from East Asia so well, but certainly in South Africa and other southern African countries, huge efforts were made to ensure that people living with HIV were getting back on antiretroviral therapy, were getting access to vaccines and getting access to antivirals for COVID when they became sick. There is no reason why someone, and there is no evidence, I think, to show that a person with HIV on proper antiretroviral therapy, they have pretty much the same experience as someone who is HIV negative in terms of the risk factors. The risks go up if they're off the antiretroviral therapy, and certainly the risks go up if they're not vaccinated. But so that's the way out for everyone, HIV positive and not. Vaccination and continued access to antiretroviral therapy.
Thank you very much. Maria, maybe you can take the question from Travis Ward, also watching us on Facebook. You spoke about the numbers that we know now, about more than 10,000 people still die from this virus per month. The question from Travis is, what is the survival rate of COVID?
Well, I mean, most people who are infected with SARS-CoV-2 do go on to survive. And that proportion has increased over time, but that's increased for a number of reasons. We have good diagnostics, we have good clinical care, we have incredible healthcare workers around the world who are seeing patients and treating patients. We have many therapeutics for COVID-19, we have vaccines. So there's a number of things, and plus a lot of people are doing things to prevent themselves from getting infected in the first place. It goes back to the fundamentals. What concerns us around the deaths is that we are only getting information on deaths from around 50 countries around the world. There's at least 150 plus countries, territories where we don't have information. That does not mean that deaths are not occurring. So among those 10 to 12,000 deaths, there's fluctuations each month, there are reporting delays, there's backlogs, so we don't have good visibility on deaths. And this is a problem because there is something we can actually do about it. So how many deaths are actually occurring right now from COVID? The argument that we get a lot is, well, it's not as bad as it was before, or it's not as bad as, and they list another disease. Well, COVID plus flu plus mpox plus diphtheria plus cholera plus all of these other things are causing excess burden in healthcare systems. Right now, the data that we have on hospitalizations comes from 35 countries. That's it. And from that data, we know that there are hundreds of thousands in hospital right now for COVID-19. We only have data on ICU from 26 countries at the moment. And so there's a significant burden we're not aware of. Again, not as bad as it was in 2020, 2021, when we didn't have vaccines rolled out, we didn't have therapeutics. But there's a lot that we feel that we can do. And the reason that the impact is less is because of all of these different factors: good surveillance, good testing, good therapeutics, good vaccines. But that doesn't mean we could let down our guard. So we have messages for individuals about how to keep yourself safe, but just as much, we are working with our member states to ensure that the capacities that were expanded and strengthened during the last 4 years are maintained, are calibrated. You know, as Mike pointed out, we can't have surveillance at the level that it was at the peak, but we need to calibrate this going forward so that we could track the virus. And remember, the virus is evolving. This virus is circulating in every country, and people are getting reinfected multiple times. So we're not only worried about the acute disease and causing death right away, we're worried about post-COVID condition, and we're worried about repeat infection in the long term, so 5, 10, 20 years from now on organ function. We're in year 5 of this pandemic, which is really quite incredible, and the virus is here with us. So what more do we need to learn? And the answer to that is a lot.
Yeah, and I think also that expectation, year 5, and you know, it should be over by now. But if you look at the history of pandemics and influenza pandemics, their impacts reverberate. They're like a spring. Mm-hmm. You know, they keep going, and then they eventually peter out. So it starts, and it's like that, and then but those waves continue. You throw a stone in the water, big wave, it starts, but it continues. And I think we're really seeing that wave-like behavior. But the interesting thing here is it's very hard to predict those waves, because we would have assumed by now these waves would have settled down into some kind of pattern where the virus, in association with the humans and the environment and the climate, that we would drive the wave by our behavior. You know, we all go outside in summer, the rates go down. We all come inside in winter, the rates go up. So it's nice. It's an easy correlation, right?
Yeah.
And that's kind of what flu does. And in the middle, in the equator, where it doesn't get hotter or colder, it wobbles around the place. And many people expected COVID-19 or SARS-CoV-2 virus to settle down into that kind of pattern. It hasn't. Okay. It seems to have settled into a pattern of, again, that idea of time and distance. Over a period of time, some immunity is lost, and the virus drifts a little bit, and then it's able to exploit that gap in immunity, that waning immunity, and in other words, returns and starts another wave of disease, but each time causing, in many ways, less death, less hospitalizations. But we have to be careful, because any one of those new waves, we have to be vigilant, not scare people, part that everyone has a good life. But if you've got an underlying condition, you need to protect yourself, you need to be vaccinated. But we, in the public health community, not the ordinary people in the streets, we need to be sure that this virus, as it tracks and it moves, and in time and in place, that we keep a very close eye on this virus. And as we do keep a very close eye on influenza viruses. And there are again, people out there may not know this, but there are millions of samples taken every year of influenza.
Yeah.
And those samples go to National Reference Centre, over 160 reference centres. And those samples, the most concerning of those, will be sent to the 6 WHO Global Reference Collaborating Centres. And it's from those, all of that work that we develop the flu vaccines candidates for every year. It's from all of that work that we develop these candidate pandemic vaccine strains for any new avian virus that comes along. All that's happening in the background. Being ready all the time, ready to understand exactly what the epidemiology is, what the virology is of these viruses. We need to add SARS-CoV-2 to that pantheon, and other viruses for that matter, so we're not caught the next time. So that all takes a tremendous amount of energy in a program like ours, where we're dealing with multiple events. I mean, as of last Friday, we were dealing with 231 ongoing events around the world, of which 42 were graded emergencies. In other words, emergencies that we have formally graded that require a WHO response, be it from our national, regional, or global level. So there's an incredible pressure out there in terms of humanitarian crises, and crises driven by health crises driven by natural disasters, extreme weather events and climate, and then infectious diseases, and then within infectious diseases, respiratory viruses. And when you look at all of that, a lot needs to be done to monitor all of that. But at the center of that, historically, the major pandemics that have affected the world, that have spread quickly around the world, have almost always been driven by a respiratory virus. So while these events are very important and they require a huge response on our behalf, we always have to keep a special eye on respiratory viruses.
If I could just comment, because I think there's a positive here, right? A lot of people focus on everything that went wrong during COVID, but in the last 4 years, the capacities that have been expanded for COVID by all of the people that are out there are important for all of these emergencies that Mike was talking about. COVID is one of the emergencies that Mike mentioned here that WHO and our partners are dealing with at the present time. So work on surveillance. If you're talking about a respiratory virus, or you're talking about another type of virus, you're talking about bacteria, these are really important capacities in country. The ability for good clinical care, seeing a patient, primary health care, seeing a patient and getting that patient on the right pathway saves their lives. And those capacities that expanded are really important. Infection prevention and control in healthcare facilities that are good for COVID are important for other infectious threats, that healthcare workers are facing with their patients. But it's the same thing with even emergency operation centers, that focuses on the coordination of these types of events. We have countless member states that tell us that what they did during COVID, they're using now for cholera. They're using now for dengue. They're using for earthquakes. So what we want to do is we want to keep that muscle memory. And this is one of the major areas of work of ours, is maintaining those capacities. We will say this over and over again, because right now, a lot of people are moving on to other threats. And we get that. We're not saying only focus on COVID. That is not the message here today. But in the context of everything else, what you've done, what governments have done, the infrastructure, the systems that are actually there are so important for everything else. And that's what we need maintained. That's what we need financing for, sustainable financing. We need to support our workforce. We need to make sure that we have strong political commitment. People are saying, we need to focus on the next pandemic threat. Well, we're in one still. And everything that you're doing for COVID is helping you for that next threat, which you're currently facing and may face in the future. So that's a positive, and that's a message and a narrative that we have to get out there. Not everything went wrong. There's a lot of things that went wrong, and we know that, and we're working to make better, everything better next time. But we need to actually look at the systems that are there and make sure that we have the right investments that are keeping those operational for the current and future threats that we face.
Thank you both. I must tell you that I think that our followers really missed you, because we've been receiving a lot of questions.
Is there anyone out there? Someone's actually out there.
Exactly. So I think we'll need to keep
I thought she was lying.
Maybe we'll need to keep the answers a little shorter if you want to address more of those. But Maria, maybe just quickly, Melanie Okorie asking, is that 10,000 per month figure worldwide? I think yes, but I just wanted you to confirm.
The answer, it's coming from 50 countries. So it's only that's the data that we know from those 50 countries. There are more deaths that are occurring, but we don't have good visualization on that because the data is not reported to us. In fact, some of our teams right now are going online and they're looking at country websites to pull that into our dashboard. You'll see we updated our dashboard at the end of the year, and we're going to be modifying that over time. So yes, in one sense it is a global number, but we know it's an underestimate.
Thank you very much. Alex Samuel watching us on LinkedIn, so it's not just questions from viewers on Facebook.
Okay.
How about disease X? Recently, there was just the wording disease X was getting a lot of interest on social media, especially before Dr. Tedros participated in a panel. But I think it would be really good to explain to our followers what do we mean when we talk about disease X.
I am fascinated by the attention to disease X. I know Mike's going to want to say a lot about this, but it's not the first time that we've been talking about this. In fact, it's been years and years, even before the pandemic. You're always planning for, there's known threats and there's potential threats. I'm going to let Mike go into the disease X part of this, but no, I find it quite interesting the attention to it right now, because it isn't a new concept. It's a concept that WHO came up with, and looking at how do we prepare for the unknown. You know, you think through this. We have a priority pathogens list from the R&D Blueprint for Epidemics that was published in 2018 of listing a number of disease threats that need focus on medical countermeasures, diagnostics, therapeutics, vaccines, because there wasn't enough attention to that. All of these different pathogens. I was the MERS focal point, MERS coronavirus, Middle East Respiratory Syndrome coronavirus focal point before COVID. And we used MERS as an example of a novel coronavirus. You know, what is that next threat? We think of a disease X as an arbovirus. We think of a disease X as bloodborne or airborne or foodborne or waterborne. We have to be prepared. So what can we do in terms of your preparation that's, I guess, quote unquote, generic in a sense of getting those capacities increased across now what we lovingly call the 5 C's of collaborative surveillance, safe and scalable care, access to countermeasures, coordination, community protection, and then what can we prepare for? So for example, for MERS, we had a number of different researchers that were looking at vaccines, a number of different ones that were looking at coronavirus vaccines. And of course, before that, there were a number of different groups that were looking at different types of vaccines platforms. What we quickly did in all of that work was preparing for a novel coronavirus outbreak. We didn't know that a pandemic would be caused by a novel coronavirus, but it's really quite interesting to me that there's so much attention to this now. It's a good thing, because we've been saying that there are a lot of pathogens that are out there, and COVID-19 was disease X, and the next disease X is out there. So that preparation needs to continue. But I'm sure Mike has something he wants to say.
Mike, how would you explain to our viewers our disease X concept?
Okay. Well, first of all, there's always been, disease X in the human imagination, because for centuries we didn't understand what was killing us, but we understood epidemics. We recognized that epidemics came, people died, very often the disease moved from place to place, and then it ended, and then everyone waited until it happened again. The plague of Justinian, the great plagues of medieval Europe, even influenza in 1918 to 1920, we didn't know it was a virus. The assumption was, but nobody really knew what was causing it, and had never visualized what was causing this. So we've always dealt with this idea that something happens and we don't always know what it is. And in any walk in life, you can deal with a problem much better when you know what the problem is. Right? It's the essence of the thrill of a horror movie, is that the director is able to build suspense by not letting you fully see what the object of your fear is, and what you do is you build on human expectation, you build on those innate human fears, and it's the good novelist or the good director can play on that. And I think it's the same thing with humans. We always are more scared of that thing in the dark than we are of the thing in the light. So bringing stuff into the light and being able to understand our enemies is always easier to deal with, even if it's initially very frightening. So, over the years, I think what we've managed to do, or what science has managed to do, not me, is fully understand the things that cause these major infections, major pandemics, mainly viruses and bacteria. And we break those viruses down into families, units, and there are, I think, 12, 13 major families of viruses, and then within that you have all the different classifications, and you get down to the individual organism, like, you have coronaviruses, and then it breaks down into the various SARS coronavirus and viruses, and then SARS-CoV-1, SARS-CoV-2, and God knows how many others, right?
Hopefully no more.
Hopefully no more. And even within that, we understand what's likely to potentially cause major epidemics or pandemics. So a number of years ago, many, many years ago now, WHO, through the Research and Development Blueprint for Epidemics, which is based on our program with Anna Maria Hanau, and we sat down with scientists from all over the world and said, okay, what we need to do is identify what are those viruses that keep us awake at night. What are the viruses that are most likely to cause a major problem in the coming years? And the coronavirus has got in there, right?
They're in there.
I think MERS got in there, and
SARS, MERS.
SARS and MERS. And at the end of that process, I think there were nine pathogens were identified. But then the question was asked, what else?
Yep.
There's always something else. Because really, before 2003, no one really thought that a coronavirus would cause such a major problem. Look what we've had, SARS-1, MERS, SARS-CoV-2, right? So there's always the sense of, is there another virus family out there that could cause a problem? Or within a given virus family, is there some branch of that family that might come back and cause us a problem that we don't recognize now? That we're focused on these nine pathogens, we're very comfortable with that, but we need a disease X. We need to prepare for that particular virus that may come along, for which we don't fully understand the virology of it, we don't, and how will we react to that? How do we do primary research to deal with that? So we've been evolving that concept more and more, and while preparing for the specific, dealing with those generic issues around how fast can we do the research, how fast can we do virus identification and characterization, can we build generic vaccine production platforms that would allow us to quickly shift and produce new vaccine on existing platforms. So ways of getting ahead of the curve, even if we don't know what the pathogen is. So if we don't know the X, we can do a lot to prepare our general response. So if you were playing a sports game against an opposing team, and if someone said, we're not going to tell you what team, we're not even going to tell you the game you're going to play, but it's going to be 11 aside, and it's going to be 45 minutes each half, and it's going to happen on a field this size, the world. Well, what would you do to prepare? You don't know the team, you don't know the rules of the game, but you can prepare. You can take care of your fitness, you can take care of your strength, you can take care of your agility, you can take care of team morale and equipment, and you can deal with tactics and psychology. You can deal with a lot of things. You can get to the ground on time, all of those things. So there's an awful lot you can deal with in an unknown situation if you recognize the unknown and then say, what is known? What do we know we're going to have to do in the next we're going to have to scale up clinical care. We're going to have to build manufacturing capacity for vaccination. We're going to have to scale up diagnostics. So we're going to have PCR-based diagnostics, and we're going to need antigen-based diagnostics. We're going to need oxygen, and all of those things, right? And we're going to have to deal with the psychological impact, and we'll probably have some kind of post-viral condition to deal with as well. So you don't have to be a rocket scientist, and I'm not one, to work out that there are certain things you need to be ready for. And that's really what we spoke about in terms of pathogen X, but also in getting scientists around the world to keep an eye out for unusual pathogens causing unusual patterns of disease, so that someone working in a lab doesn't think, there's only 9 diseases on this, so this virus that I've just isolated that killed 20 people, it's not on the list, therefore it's not a problem. You need that scientist, you need that doctor to say, hang on a second, I've just found something that's causing human disease. It's not on that big list. Maybe I should tell someone. So I think that's part of another reason too to have this disease X. So you're putting out a description of a suspect without a photograph, with a general description saying, if anyone sees this, please let us know, right? So in a sense, you've got a poster with the 9 most wanted, and then one with X on it saying anything else, and anyone else you see that looks suspicious at this point. So that's the concept behind Disease X. Now we've moved on. We're evolving that concept, working with colleagues around the world, with many research institutions around the world, like NIH, like with CEPI and others, working on this concept of virus families. I'm going on a bit now, but I think it's important. I mentioned those virus families before, and all viruses end up in one of those virus families. So we're really looking at whether we can do some upstream research to develop countermeasures against families of viruses, so that we've done a huge amount of the work in developing diagnostics or vaccines or therapeutics in advance, and then it doesn't matter which virus in that family causes the trouble. It's almost like we're going to surround the house and make sure that no one in the family is going to cause a problem. And I think that's the sort of the approach we're taking, looking at prototype pathogens, looking at examples of a virus family and saying, do we have everything we need to deal with that, while doing still the specific research. So for coronaviruses, we will still work on MERS, we'll still work on SARS-CoV-2, but do we need to take a more general look at vaccines that might prevent all kinds of coronavirus disease, or broad spectrum antivirals that would help anyone in any virus infection. So that's what Pathogen X is allowing us to do. As you can see, it's not in itself a target, it's a concept, and it's a way of thinking about the world so we don't leave something out. It's like a reminder. It's the X on the fridge that says, buy milk, you know.
Thank you very much. We are getting some good follow-up questions to this. One is, are there any implementations to help countries prepare for future pandemics, or help getting most of the countries up to date in terms of preparedness and prevention tactics, given that some countries are not having access to basic necessities? And there's also a related question to that, not just on the country level. Are there local prevention methods, techniques that are being promoted and encouraged, or the plan is to rely on technology?
Wow.
Yeah, so
They're two
that's a
bloody
lot
good
of-
questions.
I know we could spend the whole session just talking about those. These are two
It's a
viewers
dissertation.
from LinkedIn.
It's a great.
Wow.
They're great questions.
They're really good.
I mean, it's all of the above. I mean, it's everything from government, international, to multilateral agencies, all the way down to local, to people, to communities and people. Everybody has a role to play in this. We've said that quite a lot. But there's a lot of work that's happening in the pandemic preparedness space. We're working with governments to revise all of their pandemic preparedness plans. This is our PRET initiative, which is basically looking that everybody went through COVID in the last 4 years, and many all are still going through it. They have had influenza preparedness plans, and how do you approach pandemic preparedness for respiratory diseases? How do you approach pandemic preparedness for arboviruses? There are some fundamentals that need to be focused on, and we've talked about these: surveillance, good clinical care, strong diagnostic sequencing, access to measures that prevent infections, prevent severe disease, supply chain, all the way to workforce, all the way to financing. So there's a lot of area of work in this space. But we need everyone's involvement in this, because pandemic preparedness is a constant. It's not something that goes in ebbs and flows. We do live in a cycle of panic and neglect, and there's a lot of attention to it, and then we move on to other threats. But what we're trying to do with governments, and it's beyond the health sector, because we saw with COVID that it involved every sector of government. It involved every aspect of society. We needed all of our government partners, our UN partners, all of our civil society partners, healthcare worker associations, the faith-based communities, youth leaders. Everybody had a role to play. And what we see here is, going forward, we see that investment in people and not only coming up with science-based solutions, and of course there's the scientists out there and the collaborators that are out there, but coming up with interventions together co-developing these interventions so that the implementation can actually get picked up. Remember, at the beginning of this pandemic, we were using public health and social measures. We had very little research on public health and social measures before. And now there's a global community that has come together. And this is actually with support from financing from Norway, which we're very grateful for. I specifically mentioned because this has been impossible to finance in the last couple of years. Now we are looking at research. What are the intended consequences of public health and social measures? And what are the unintended consequences, the social impacts, the financial impacts, so that going forward we can make more precise recommendations and that we can support people in preventing onward spread, but also not have the same kind of societal, mental health, financial impacts. So it's massive, Alex. I mean, the work that we are doing is across capacities, in terms of looking at the different capacities like surveillance, like infection prevention control, but it's also disease-specific threats around the respiratory diseases, the arboviruses, the epidemic bacteria, the high-threat zoonotic pathogens, and it's across prevention, preparedness, readiness, response, resilience, recovery, all of that space. So it's multidimensional, it's multi-partner, it requires sustainable financing, and I don't know if Mike wants to comment on that, but this isn't something that you could pick up and find some coins in the, in your couch cushions to finance. This is something that actually needs a required and a sustained investment, because it's not a matter of if, it's a matter of when. And preparing for that requires some political will, financial will, and all of us to really realize that we've got a really important part to play in prevention as well as response.
There is a follow-up question to this, Mike, that I think maybe you can take. From Diego Alejandro Yasno Salazar, also watching us on LinkedIn. Mm-hmm. If the next pandemic event occurs in several years, would the health systems be prepared?
That's a fine name. Diego Alejandro.
Yasno Salazar.
Yasno
if I'm
Salazar.
pronouncing well.
Okay. And the question again, sorry, we'll just...
If the next pandemic event occurs in several years, would health systems be prepared?
I suppose that's a choice. I would say in a great majority of the world, probably not right now, given the levels of damage done by this pandemic, given some of the inherent weaknesses in those systems, given the lack of domestic and international investment in health systems resilience. And that's doubly sad because it would take relatively little to fix the problem. And that's what we've got to try to do. The Joint Finance and Health Task Force of the G20 did some work and commissioned work to look at what the costs were of pandemic preparedness around the world. And they thought that really we were probably at the moment investing, collectively around the world, nationally, internationally, maybe 20 billion in that, and it probably needed another 10 billion or so a year to really significantly improve pandemic preparedness. That sounds like a lot of money, but in the great scheme of international financing spread over 190 for 200 countries, it's really a tiny amount of money when you consider that the pandemic cost trillions, literally trillions of dollars. And how do you count deaths, and how do you count the psychological suffering and the disruption? That's not costed into that, but just economic, social, and health losses in the trillions. And we should be asking ourselves the question why we're not prepared collectively as a global society to spend billions to solve $1 trillion problem. Now, we've been been modelling this over the last few months and looking at spreading out the cost of this pandemic or any other pandemic over each year, in the same way you do the same in your house when you're buying house insurance. You think about the value of your house and you think, I'm going to have to pay €100 a year or €1,000 a year to insure it. You work out that you might never recover that money. But it's a good investment, because if at any moment over that 50 years that you own the house, the house were to burn down, you're going to recover your costs, right? So what you do is you annualize the cost of the investment and you pay that out. And you say, okay, over 50 years of owning this house, I'm going to pay $50,000, and that money is gone. But my house is worth 500,000 and my house is worth $1 million, which means at the very end of it, I'm going to ever end up paying 5% of the total cost of my house in insuring it so that I get back all of the money if it burns down. Now, that's the principle of insurance. We need to apply the same principle here. How much are we prepared to pay collectively on an annual basis to avoid the trillions of dollars and the suffering caused by the pandemic? And we're not ready to answer that question yet. And we're still nickel and diming this issue. Many of our sister agencies are struggling to get the resources they need to do pandemic preparedness. We're struggling in our program. We're at least $100 million behind in actually getting the core resources we need to do our work for the next 2 years. So that's the reality. The reality is that those entities and agencies do not have the resources. And that's even more acute in many national settings, because in many developing countries, so much was spent on health during the COVID pandemic that ministries of finance are coming looking for their money now, and they're cutting back in health at the expense of other ministries. So in fact, we're not just going back to the way we were before, but many health ministries have been squeezed lower than they were before. So we're having a relative dip in investment in health. So it's very hard. Diego says it's not will systems be ready? They may even be less ready. Will they be any better? They could even be in worse shape. And that's really, really worrying. Having said that, there's a huge amount that can be done. Right? There's a huge amount that can be done. And it's not all technological. Mm-hmm. And we saw this in the pandemic. Most of the assistance people got in the pandemic wasn't technological. Yes, we got diagnostics, and yes, we got vaccines, and we'll need to do that again. We'll need to make even more, and we'll need to make sure that they're distributed on a much fairer basis, right? Absolutely. But when communities are caught in a crisis, it's the community that reacts to the crisis. And it was communities who reacted to this crisis in COVID. It was the communities who supported each other. It was the communities who gave each other the assistance that they needed. And when you look at that in diseases, for example, like vector-borne diseases, the solutions to dengue and other huge diseases aren't necessarily technological. Mm-hmm. They're about getting rid of upturned cups. That cup has water in it. That is the breeding ground for dengue. Dengue doesn't breed in the normal river systems. It breeds in human-made wastewater. And when people are living in big peri-urban slums, we need to be investing in those communities to get rid of those cups and tires and upturned cans. Who better to do that than the community themselves? Technological solutions, same with cholera, and dealing with making water sources safe and protecting water sources and ensuring that people have proper containers to put their water in. And all of those things can be done at community level. And I think it's very often, there's this overcomplication. Pandemics, epidemics have been around for centuries. Human beings have survived each and every epidemic and pandemic that's ever occurred, or else we wouldn't be here. Right? That's a fact. And we evolved to survive. And we survived to evolve. That's the way it works. That's the great game of evolution. So we are programmed to survive. The only question is how much loss and suffering we have along the way. And we've evolved into a society that doesn't tolerate that kind of loss. We don't want to lose 1/3, 1/2 of our population. We don't want our families decimated by these viruses every 10, 15 years. Maybe that was the human experience in the past. That's not an acceptable human experience now. That's not what we want. And if we want the difference between living in a natural world where we will be wiped out every generation by a virus or every second generation by a virus, if we don't want that to be our future biology, then we've got to invest. We've got to actually stack the deck. We've got to create a circumstance in which we're able to detect, we're able to react, we're able to protect our communities, either through technology or community action. And we need to invest evenly in both. Technology will not solve epidemic issues. So many of the epidemics we see around the world today are driven by poverty, social exclusion, lack of investment in infrastructure, and quite frankly by corruption. And it's local people and local communities that we need to invest in. If we can link human ingenuity and innovation at community and scientific level, if those two things can come together, when scientists and communities engage in an equal partnership, where governments facilitate that, where you can really drive real social innovation and technological innovation and a government can bring that together in a mutually beneficial way, then you have something quite special. And I think we're there. I don't think it's a bad news story. I think COVID showed parts of it. We saw green shoots. We saw examples of it. The issue now is, can we make that the new norm, right? Can we create a new normal? There's so much geopolitical divide. There's so much bloody hate in the world now, and we're so divided that actually this is one area where we can actually come together. It's one area where we, as a species, can survive the next pandemic better together. And the sad fact, or I suppose the hopeful fact, is we can only do it together. There's no other way, because regardless of where we put our borders and regardless of where we fly our flags, we're biologically the same species, and therefore we live or we die together. So we cooperate or we fail. That's simple. And I think when we look at what's happening in the Accord negotiations and the IHR negotiations that are ongoing, I think member states are seeing that. They're seeing that this is one area, regardless of our differences, where we must cooperate. And we saw that. We got rid of smallpox together in the 1960s and early 70s. And we did it at the height of the Cold War, with the USSR and the United States of America leading the charge at the height of the Cold War. We knew how to cooperate even in very, very desperate times. So I'm hopeful. I have more faith in the human condition than maybe others. Maybe I'm misguided.
Thank you, Mike. This is a Monday motivation. An answer from you. Thank you for that. I think it's hard now to continue the conversation after this, but we still have a couple of questions more, I think, that we should address that are in relation to the current pandemic that is not over yet, as you rightly said. So Sriya Srikamur was asking, now that we are not in lockdown and it is not practical for many countries considering the number of cases has increased, what should we do as working civilians to be cautious and not be part of the contagious chain?
Well, first of all, just asking the question is wonderful, to say, what can I do to do this? There's a lot that you can do. So we focus on two different aspects. One is to prevent yourself from getting infected. We used to have this campaign, we still have this campaign called Know Your Risk, Lower Your Risk. And it's about taking some common sense steps, to prevent yourself from getting infected. If you have access to tests, not many people have access to tests these days, but if get a test if you're feeling unwell and if you're feeling sick, seek clinical care because there are good antivirals that are out there that can prevent severe disease and death. Taking common precautions like wearing a mask when you're in crowded spaces, improving the ventilation where you live, where you work, where you study. We're also working with governments on that as well, not just as an individual measure, but also improving the air that we breathe. Making sure that if you're going to be out, we have some holidays that are coming up. We've just passed the big New Year celebration, but we have the Chinese New Year coming up, and we have some New Year celebration in the Asian and the Western Pacific. A lot of people are traveling. While you're traveling, take some precautions, especially when you're crowded. So put on a mask. Do use your hand gel because that's not just good for viruses, but it's also good for bacteria that are out there as well. Get vaccinated. So we have recommendations that are out for the entire world, focusing on COVID-19 vaccines, focusing on the highest risk groups, especially if you're in the oldest age group or an older age group and have underlying conditions. Please get vaccinated. Our recommendation is to get vaccinated within 6 to 12 months, depending on when your last dose was. But remember, COVID's not the only pathogen that's out there. Get your flu vaccine. Make sure you're up to date on your health checks. That's really, really important. And really spread good information. There's still a ton of misinformation and disinformation that's out there. We see it every day. We're trying to address this point by point, but we can't get to all of it. But look at the information that you're getting and make sure that if you pass that information on to others, it comes from a verified source or that you know where it's coming from. And seek some information from your healthcare providers. So there's a lot that you can do on this, but get tested, get vaccinated. If you are feeling unwell, get tested and seek clinical care, but make sure that you're up to date on your vaccines. And again, it's not just for individuals. We're also making sure that governments are providing those tests. Governments are providing those vaccines. Governments are providing these antivirals. We still have a massive issue globally on access. So we recognize that even though we're telling individuals what to do, it may not be possible for you to do in the situation that you're in. We're also working with governments to make sure that they provide that with you, starting with good information, as well as testing, therapeutics, and vaccines.
Thank you, Maria. There is actually a question from Eslam who is asking, is WHO working with countries? I will shorten the question, basically to align the vaccine policies, which vaccines are, because the concern here is that some countries are not allowing certain vaccines or the policies are different on the number of doses. So is WHO working with countries to make those alignments?
National vaccine policy is a sovereign issue. And there are those out there who would say that WHO tries to take control of national sovereign decisions. We don't. Health is 100% within the sovereignty of each and every national government around the world. And vaccine policy is equally so. We're a technical normative agency for this particular purpose. We gather science and evidence, we bring together expert groups from around the world, and we make recommendations to member states regarding vaccine policy. It is entirely for our member states then to decide how they take that forward. We also do a pre-qualification of vaccine manufacturers that allows us to certify that certain manufacturers who meet this grade, that it's that countries who don't have that same capacity to pre-qualify those manufacturers can rely on WHO pre-qualification. So we explore and develop recommendations for policy, but they're not binding in any way on governments. Obviously, we also monitor vaccine safety. We monitor, safety of all medical products, for that matter. So WHO provides that scientific basis of evidence, but not vaccine policy. I can't think of. There are different. The policies aren't that different when it comes to COVID. I don't think there are regarding boosting mainly, and age groups. I think maybe, and what's defined as underlying conditions. And again, our SAGE and other people have discussed that. I think
I mean, it is a little confusing out there. We get that because some policies are different, but what we recommend and the policies that we are helping governments to set, and as Mike said, it's up to the governments to do that. We think of the whole world, so we look at the whole world, and we look at the reliability and the vaccine effectiveness, but also the access to the vaccines themselves. So our focus has always been really targeting the highest risk groups. Vaccines were designed to prevent severe disease and death. They do have some impact on transmission, but what they're really good for is preventing severe disease and death. And a big message out there is that when it is your turn, when you need an additional dose, get vaccinated. The vaccines that are out there, whether they are the vaccines based on the ancestral strain, or they're the vaccines based on the bivalent or the XBB monovalent, all of these vaccines are working to prevent severe disease and death, including against the circulating variant, this JN.1, that is now dominant worldwide. And that's really critical. But, countries are working with all of their people to make sure that they increase vaccination demand and make sure that especially those who are most at risk get vaccinated. But we are doing everything we can to ensure that there are policies in place, but not only those policies, but also access. And that is still a significant problem worldwide.
Thank you, Maria. There is a follow-up question, please. Is there any COVID vaccine that can prevent the virus mutation and also eradicate it?
Oh, I wish. It would be lovely if we were in a situation to eradicate this virus, but unfortunately we're not. There are many vaccines that are out there. There are still some vaccines that are currently in development that are focusing on preventing transmission. That would be wonderful. These intranasal ones, that would be a game changer. But the vaccines that are out in countries, there are many of them that are licensed, that are shown that they are safe and effective against preventing severe disease and death. These are the vaccines that we need people to receive and to get these additional doses when it's time for them.
Thank you very much. Before we end this conversation, I don't think we can end it without mentioning people living with long COVID. And there are two good questions about it. One is looking for explanations on long COVID, what to do as home treatment. And the other one, what is the scientific update on long COVID?
So I'll start, but we did do an EpiWin seminar last week. It's up on YouTube, and we gave a full overview of the whole global COVID situation. But in particular, there was a section on post-COVID condition. Dr. Janet Diaz was with us, who also answered some questions on that. So I will refer the viewers who are asking those questions to look at that because that's a proper answer. Our understanding of post-COVID condition, or what some people call long COVID, is evolving. It's changing. It's growing over time. Our understanding of this is around there's a meta-analysis that was done. It was done pre-Omicron. So we estimate from this meta-analysis that about 6% of symptomatic individuals with COVID have gone on to develop post-COVID condition. And this ranges, affecting many different organs of the body, the lungs, the heart, the brain, and really causing some very debilitating effects on people. This is real. So we have worked on recognition. We have case definitions for adults and for children. We have case report forms that we want doctors to be able to use that so that we could systematically collect information on people suffering from post-COVID condition in an effort to better understand this and its duration. Most people, depending on if you're hospitalized or not, suffer between 4 to 12 months, but some people even longer. Many people do recover, but again, we're still learning about this. Our teams are working on treatments, looking at preventative measures, but also treatments, rehabilitation. There's a lot that's under study in terms of specific treatments. PAHO, our organization in the Americas, has issued some guidelines on this, or looking at different treatment options. We're doing this at a global level as well. And we're working to make sure that we have good research. We have good cohort studies that are established around the world. Again, this really requires financing, but there's still quite a bit that we don't know. And we do want you to know that this is something WHO is working on. So I would refer you to that longer summary that we have on post-COVID condition. And just know that we haven't forgotten this. This is a major area of work for us, and making sure that patients get the care they need, focusing on multiple organs, making sure that they get a comprehensive assessment from their healthcare providers so that they get on the right treatment course, or the right options for them. But it is something that requires a lot more investment, a lot more study, and it's something that we will continue to report on. So we don't have a full answer. I gave you a long-winded answer. I'm really sorry. But it's something that we just don't have all of the answers on right now.
Thank you so much, Maria. Maybe Mike, something from you?
No, I just want to, I just very quickly reflect, not on COVID, but just to pay my respects to a great man who died at the weekend, and I say it in the context of COVID because his name was John Ryan. He was deputy director at the Director General for Health and Security at the European Commission. No one probably out there, very few might know John, but he's been a huge piece of the whole European Commission's work on protecting the health of European citizens and beyond the European border for so many years, and was a major player in the work that was done across Europe and across the world in COVID. Was a major player in establishing the pandemic fund. Someone who's been deeply involved in this. So John passed before his time. He just retired, and I just wanted to mark the passing of a wonderful public health servant, someone who served you all out there, especially you who hold European citizenship. And there may not be plaques erected or whatever it is, but I know that John worked so hard over so many years to fight for health security and health protection for people and citizens, and I'm sure his family are mourning him today, and I just wanted to recognise his passing and celebrate his life and what he contributed to health security and what we do in pandemic preparedness.
Thank you, Mike, and sincere condolences to his family and colleagues. And unfortunately, we lost so many colleagues and experts and health workers during this pandemic or other epidemics and crises. So our thoughts are with them, and thank you for reminding us of all the people who are protecting us out there, but not getting as much visibility. And I do want to thank to all our viewers from Nigeria, the US, Pakistan, Dominican Republic, Ireland, Tanzania, Germany, Mexico, India, Afghanistan, Turkey, Tunisia, Mozambique, Cameroon, Ethiopia, Botswana, Brazil, Iran, Ghana, Uganda, Colombia, the UK, Algeria, South Sudan, Greece, Niger, Italy, Egypt, Armenia, Peru, and many others. It's a long list of countries, and it was a long list of questions. I do apologize to those which questions we didn't manage to answer today, but we will look into ways to be with you more often maybe and address your concerns, if not in this format, but through other products on our social media channels. So please stay with us. Also follow our website and check the YouTube with the event from last week. It's called WHO Update on COVID-19. So it's somewhere on top of our YouTube channel. Thank you very much and stay safe.